I'm Dr. Ruth Doughton. I'm a board-certified adult psychiatrist, and today I want to talk about protracted withdrawal. So protracted withdrawal is a brain injury that is caused by the abrupt discontinuation of certain psychiatric medications. Now, it's a relatively uncommon condition, and most people can discontinue their psychiatric medications without developing this condition. However, we really don't know the prevalence of this condition because we don't have any data that's looked into the prevalence or incidence, and it can be potentially devastating for those who are affected by it. It's also not something that's routinely discussed when these medications are initiated. And so most people have no idea that this potentially devastating condition is even a possibility. This phenomenon is different from typical withdrawal, which is typically short-lived and can be reversed by reinstituting exposure to the medication. Protracted withdrawal is a brain injury that leads to neurologic changes and is not reversed when the drug is reintroduced to the system. The recovery takes place over time through really slow neuroplastic processes, and it's most common with the use of several antidepressant medications, including SSRIs, SNRIs, and mirtazapine, as well as benzodiazepines. We don't really understand the mechanism behind it, but it may be related to excitotoxicity damaging neurons, triggered autoimmune responses, or irreversible adaptive neuronal changes after prolonged exposure to the drug. Symptoms can essentially affect every organ system and can include things like severe anxiety, insomnia, cognitive impairment, dissociation, sensitivity to sound, sight, temperature, and touch, balance issues, rapid heart rate, GI upset, and akathisia. And one of the most dangerous potential adverse effects of this condition is thoughts of wanting to hurt yourself. It can take years to recover, and the treatment is largely supportive. So the best thing to do as far as this condition is to prevent its occurrence. And this is done through slow, cautious tapering of psychiatric medication. So you only want to taper as quickly as is tolerated by the individual. So we usually recommend hyperbolic tapering, which would start with a 10% reduction at a time, and that could potentially be escalated depending on what is tolerated by that individual. Of course, there are rare instances where even a single exposure to a medication could trigger this brain injury. So if you're starting one of these medications, make sure to talk to your doctor about the risks versus benefits of these medications, as well as your long-term goals of whether or not you want to be on this medication short-term or long-term. And don't be surprised if your psychiatric prescriber is not familiar with these concepts. Unfortunately, this is not something that we're routinely taught about in our training. Feel free to look into resources like Dr. Yosef and his taper clinic, the Maudsley Deprescribing Guidelines, Mark Horowitz's work, as well as Anders Sorensen's new book, Crossing Zero. Wishing you all good mental health, and I'll see you in the next one.